This year, for the first time in 11 years, the American Association of Neurological Surgeons and Congress of Neurological Surgeons Joint Section on Spine released its second ever, the last in 2002, of the guidelines for the management of cervical spine and spinal cord injuries. And this is something, if you're wondering about guidelines and where it's been looked at specifically in the care of spinal cord injury patients, it really, you have to turn to the physiatrists, the rehabilitation physicians. And a lot of that is because they look back on hindsight, and there still remains in those, even who are left in charge of taking care of these patients, a great deal of nihilism. A belief that this is a horrible injury, it's occurred, we can fix the orthopedic problems of the spine, and the spinal cord injury itself is a done deal. And I think nothing could be farther from the truth. And it's always a pleasure when you have people like Dr. Dietrich and his colleagues and others who believe similarly. And one thing that's very clear when you look at guidelines and physicians trying to enforce them, and you look through the rehabilitation physicians, that inpatients are, forced to listen much more than outpatients. And outpatient physicians obviously have a lot more of their own ways of doing things individually, and outpatients themselves have more people, thank you for leaving, Dr. Hempel, and have more influences on their lives or other people who are responsible regarding their adherence to such guidelines. There is a lot of variation also between geographical locations and different hospitals and how these things are formed. And if you look, for instance, you look at two very important things, the issue of documentation of nutritional status and watching what happens, particularly as motor function declines, there is less need for caloric intake. This may be unregulated. It may be that a quadriplegic has difficulty getting the nutrition on demand when necessary. And so compliance ranges anywhere from 15 to 85%. The same for pressure relief regimens. Can the patient move himself around? Can he participate in moving? Is he become too big for his older adult parents to care for? And therefore, this is anywhere from 5 to 65%. Even at its best, only 2/3. And obviously, adherence is always better to some guidelines than others. Those things we agree with, we tend to like a lot more. And I'll come back to that issue when it comes to inpatient management in particular. There are a lot of issues regarding standardization. How do we track these people? And this has come up in the issue, in particular, of how we interpret data when it comes to clinical trials in spinal cord injuries, particularly pharmacological data that I'll come back to. So these guidelines are out now. There are some injuries that are just not addressed. This gentleman was a window washer who was on a scaffold on the side of a building, slipped, the rope got around his neck, and this is a complete dislocation, subluxation. This obviously is a lethal injury. There is nothing we're going to do to the disrupted spinal cord. The topics covered in the guidelines run from various and sundry medical issues, radiographic assessments, and initial reductions, and then the manual essentially for the neurosurgeon. What evidence is there to do what operatively for internal fixation as well? In a longer talk, I would cover as things I think important for the general audience and particularly for neurointensivists, issues regarding, and I encourage you to read these, and I'm giving you some hints where you might start regarding immobilization and initial clinical assessment. We'll cover some of these monitoring blood pressure, pharmacological issues as we go through, and I'm going to go over where there are great data now regarding surgery. The issues of infection prophylaxis I mentioned because they're not covered quite as well, and they become an area of great practice variability. The bottom line in looking through studies, and good ones have not been done in the last 20 years, excuse me, and particular is the issue in patients with bladder dysfunction and self-catheterization, or our catheterization of these patients, and suppressive regimens of trimethoprim sulfamethoxazole. And it's true, if you give antibiotics, you reduce bacteria and infections recently after spinal cord injury. But at some point, you get along to where you get colonization and you get breakthrough bacteria with organisms that are resistant to the sulfa combination. And that obviously limits the usefulness of this strategy. And much has been the case for all sorts of regimens of prophylactic antibiotic administration, as we'll get to. So it is not something that is recommended, and I think this is one chapter that is not thorough in terms of what's there. The bottom line, there is no clear role for this. One other place that the issue of infection prophylaxis comes up are for penetrating injuries of the spine, such as this gentleman. This is a through-and-through bullet entering from the front of the abdomen straight through the spinal canal, right, and taking the conus medullaris. There are, at least one review has suggested broad-spectrum antibiotic use for more than 48 hours or more than 7 days, but that's when you go looking in the general surgery trauma literature. And it's essentially, the feeling is if the gut has been violated by the penetrating object, that therefore it's introduced infection. Now, there are various and sundry problems with this strategy because the antibiotics used in these series are not antibiotics that penetrate the spinal fluid. They were second-generation cephalosporins. So the chances that they actually got to the target are nil. So retained bullets are not thought to be an infection risk at this point. And this has vacillated back and forth from the days of Harvey Cushing and to Mike Carey in the Vietnam experience and the experiences through the Iran-Iraq wars, whether you go chasing these bullets or not. And the answer appears to be no. Leave them be. You can do more damage by trying to treat for them than to see if and treat infection if it comes. We'll talk about the issue with timing for fracture fixation because I don't think it's any longer a debate. I've never thought it was a debate. Now we have proof. Right? And there is some proof in terms of infectious risk that fixation, at least within the first 72 hours, can reduce the incidence of ventilator days, hospital charges, and pneumonia as well. So do you need these when you have penetrating injuries? Probably not. At least the strategies there, patients may as well have been given placebo because the antibiotics were not penetrating the spinal fluid anyway. So, that said, I want to get on to areas that are covered in the guidelines that remain particular areas of consternation and difficulty for the clinician, particularly those acutely in the care of these patients and particularly during their intensive care unit stays. And there has always been concern regarding, can you give the trauma patient in general anticoagulants? Can you give anticoagulants to somewhere where there has been a defined risk of epidural hematomas with violation of the dura, as in with low molecular weight heparins? And the bottom line is that this is an intelligently looked at chapter, I think. Recommended prophylaxis for all patients with severe motor deficits. That means that they have a spinal level that we'll come over in a minute. Low molecular weight heparins are the best answer. That was without question. Low dose heparin is a fine alternative, but it should be used in combination with pneumatic compression stockings or electrical stimulation, which is rarely used. But these at least appear to be in the literature acceptable alternatives for prophylaxis. So if someone is afraid of the uncontrolled nature of low molecular weight heparins, which we cannot in real time practically monitor, factor 10A activity, then low dose heparin, much as we do, is a fine alternative in conjunction. Contrary to some of the other orthopedic literature that had looked at low doses of warfarin in the area of 2 to 3 milligram fixed doses, that this is not recommended as prophylaxis. This was ineffective and led to bleeding complications elsewhere. And administration within 72 hours is what's recommended. The data, the reason that comes about is that there are relatively few data in the first 48 hours. And that's mainly because even when we had tried to organize a national study, that enough neurosurgeons and orthopedic surgeons were wary and did not feel equipoise and were uncomfortable with patients in those first days getting them. We should hopefully have a cohort series out soon showing that even low molecular, unfractionated heparin given with compression stockings the morning after admission is safe, even in patients going to surgery. The other thing is that the prophylaxis should remain for 3 months until spasticity develops and tone returns in the paralyzed areas of the body, muscular spasticity then to compress veins. And filters are not recommended, be they greenfield or otherwise. They're backups for people who fail or don't tolerate anticoagulants. There are general other critical care issues that I just want to remind you about, and this is meant as an update, so these are not new things, but the concept of remembering how the airway is managed and not to disrupt the alignment of the spine when doing so in patients with suspected injury, remembering that those with cervical injuries often require some mechanical support. Those with levels above C5 will almost uniformly require support. And the other issues with hemodynamics, which I would love to spend more time but don't have enough allotted, for discussing the issue of neurogenic shock when the sympathetic system is out, particularly with paraplegics and quadriplegics, paraplegics above T4. The option certainly is to avoid hypotension, but is to try and maintain normal perfusion for 7 days post-injury. I am actually a very strong believer in this, and I'm hoping that we can organize at some point to try and prove this. If patients don't need to stay in the ICU for 7 days, given the lack of strong evidence, then we don't leave this as the only reason to keep them there. But while they're there, we certainly try to support this. The issue, obviously, in a lot of these things is the principal focus of what we're at is to prevent secondary injury. Edema that compresses small capillaries within the spinal cord, leading to infarction and more destruction. And while there is a lot that's been made regarding axonal injury, retraction balls, and otherwise, that a vast majority of the initial forms of secondary injury are related to edema and pressure of the microvascular circulation. It becomes a secondary vascular disease. Right? Unfortunately, when we're looking for this, there is a paucity of very good disease-specific data. We have to draw from other trials that were not focused on spinal cord injury, be they the albumin resuscitation trials, transfusion trials in critical care, the insulin infusions. We just don't, even at busy centers, we don't see enough patients per year to do these alone. Right? So we have protocols, guidelines, standardized orders, and try to individualize. Well, let's talk about possibly the most controversial problem, where politics, I would argue, enters more than science into what has happened. Now, let's take, for instance, a gentleman case here. 73-year-old gentleman is practicing Tai Chi, and he slips. He's awake. He complains of some pain in his neck and has no movement or sensation in his arms or his legs. His blood pressure is a very wide pulse pressure. Diastolic is not auscultatable, but has a reasonable systolic pressure. And he's awake, he's breathing all right. His blood pressure now is about 130/75, and it's falling as time goes on in the first 5-6 hours to 100/60. His heart rate remains essentially invariant as his blood pressure falls. A good sign that this is probably neurogenic shock, that he has denervated his heart and is losing sympathetic tone. And he has a C5 level, meaning that that's the last fully functional level is at C5. He's what we would call, as I'll come to, an Asia B. He is complete in his motor dysfunction and has some sensation below that level. So he can shrug his shoulder, he can barely anti-gravity move his biceps on the left. So the last complete level is at C5. I remind you, don't try and read this, but the American Spinal Injury Association, or ASIA, has well-done bedside charts that nurses, physicians can use to track motor grade and strength. They relate particular functions and muscles to the spinal levels from which they originate, and they can be useful then to not have to remember. And remember, just as I do, is Asia A are complete. There's no sensory function, no motor function, even in the sacral segments. Asia Bs are incomplete. They have sensory but no motor function preserved below the neurological level, such as the gentleman I just presented you. Asia Cs are incomplete, and what we call is they have some preserved motor function, but I like the term that's used, motor useless, meaning I can move my fingers, but I can't hold a toothbrush. So that I have some motion, but it's not useful for anything. That would be an example of an Asia C. The Ds are incomplete. They have motor useful. I can hold a toothbrush maybe with an assistive grip, but my strength isn't normal. And E for excellent or excelente would be normal. That's how I remember which direction the scale goes. Got to keep things simple, as I've told you. So our gentleman, for instance, here his problem is ossification of the posterior longitudinal ligament. He has here C2, 3 at 3, 4. You can see this ossified ligament is in place with subluxation and dislocation here. And you can see also there's edema and T2 signal high already within the spinal cord, this done within a few hours of his injury. So, who's going to assess him? Well, he's seen by the emergency physicians, the trauma surgeons, the neurosurgeons, and the only person that documents a full exam, luckily, is the neurology resident. But somebody's got it from the beginning. Do we give him steroids? Come back to that. Does he need surgical decompression? I showed you where he's entrapped. What are we going to do about secondary cord injury? His blood pressure is falling. I've described to you this as a vascular secondary disease. We're going to augment his blood pressure somehow. He has no sympathetic tone. If we just give him fluids, they'll pool. We're going to need to give him back chemical alpha tone. We're going to have to do something about those secondary complications we talked about, be they skin integrity, bladder and bowel issues, right? And I like to have the rehabilitation physician seeing these patients the morning after injury. So what do we do with this? Well, we'd say we turn to clinical trials and we turn to the guidelines. The guidelines being a group of experts together to look. I want to focus on a couple issues. In particular, this issue is probably the most contentious of anything in the previous guidelines, and I think things will be no worse in this version of the guidelines. Goes back to a randomized controlled trial of methylprednisolone or naloxone in the treatment of spinal cord injury, the National Acute Spinal Cord Injury Study, or NASIS. And we conclude that in patients with this injury, treatment with methylprednisolone and the dose used in the study improved recovery when the medication was given in the first 8 hours. Now, if one randomized trial doesn't help, go back and do another one. And now methylprednisolone for 24 or 48 hours versus a 21 amino steroid for 48 hours. And this was NASIS 3, showing that methylprednisolone initiated 3 to 8 hours after injury was even better if given longer. And so you have these guidelines that come out, as I'm going to show you, and have done an about face on what was written in 2002. Now, speaking openly and not behind anybody's back, because I have complained openly as part of the executive committee for the Joint Section on Neurotrauma and Critical Care, is that the reinterpretation at this time has as much to do with politics as it does with science, unfortunately. There are a second group of guidelines that are put out and essentially come from the orthopedists in their journal Spinal Cord Medicine. These are now 5 years old. And that consortium concluded that there was no clinical evidence to definitively recommend any agent, including steroids. The neurosurgical guidelines now state that the administration is not recommended. That if you're considering it, you should bear in mind that the drug is not approved for this application. The legal argument is now made. It's not a question anymore of the science, and that there is no class 1 or 2 medical evidence. I just described to you 2 randomized trials. There are scattered reports of what they consider class 3 evidence. And a lot of this may be the politics of how the group dealt with the initial investigator, willingness for the data to be re-examined, and the design of the study. We can't go back and fix the design of a study that's already taken place. We can accept it how it's done. But throwing out the baby with the bathwater seems the wrong thing. As I read it, I don't think this is what the study said. Well, steroids work, don't they? Or is the nail now being put in the coffin for their use? Right? I think a lot of it was done in the skepticism given the CRASH TBI trials, which showed clearly that steroids were associated with complications and no benefit for traumatic brain injury. And the criticisms had to do with the time criteria, that it was randomly chosen, that was this a clinical meaningful endpoint to examine everybody on the right side. It was just a matter of standardization and the clinical trial techniques of the time, right? The importance of complications just weren't noted in the trial. And the problem is that these guidelines are now written and debated by people who aren't necessarily the ones living at the bedside taking care of the patient and the complications. And this is tricky. To complain now that other treatments in their care was not standardized, now to complain 25 years later, I think is ludicrous. So do they work? You know, I thought in STASCIS 2 it looked like it, but there's no functional outcome. It's simply bedside testing. They're limited to statistical descriptions, and these complaints over people would like to share and re-examine the data. And in STASCIS 3 was this cut point was just arbitrary. There are all sorts of things. Just in the interest of time, I'm not going to go through. I suggest you go back, you read the 2 trials yourself, you read the assessment and the guidelines, and you make up your own mind. Don't listen to them, and don't listen to me. But is methylprednisolone considered the standard of care for some? It's clearly had variable adoption, and there are numerous legal cases. And in an examination that was done when the guidelines came out last time, the most common reason stated from Canadian surgeons for giving methylprednisolone had nothing to do with science. It was legal concerns that if they didn't, they'd be in trouble. And this was echoed by orthopedic spine surgeons 4 years later. So the summary, I would say that they are, despite I can't show you everything, they are the most extensively clinical studied intervention in spinal cord injury. I believe they probably provide some minimal benefit. That's my take on the literature. Don't trust me. The risk of complications are real, but they're possibly overestimated clinically. We have not seen in 15 years serious gastrointestinal bleeding, except in one patient where the resident did not give any prophylactic antacid drugs. Was that our fault or was it the drug? And this is with an experience of a minimum of 40 patients a year. Physicians always have these behaviors of I can do what I want, and if anything, where there are few data, physicians will behave in drastically random fashions. The acute interventions still need to be worried about, and is this just part of it? People looked for this to be the magic drug, and it's only part of everything that we do for their care. And I would hope that later we're going to hear some more from Dr. Dietrich regarding stem cells and other issues. So should you or shouldn't you? I tell you, I'll remind you that the protocol is written out and is available in the old guidelines. These data are, I think, weaker. This is easy to teach one thing for the nurses to expect. And in my new job in Denver, we are sitting down to have serious discussions among orthopedics, neurology, neurosurgery, rehab medicine, emergency medicine, and others regarding, are we going to decide not to follow this area of the guidelines? The guidelines claim there are some options: closed or open reduction of subaxial cervical facet dislocations. Without question, seems intelligent. You can believe that one because it seems right. And surgical decompression of the compressed spinal cord, especially if the compression is anterior and focal, meaning traumatic discs, subluxed bodies, fractures, to come from the front and take care of it. But there's no standard regarding indications now in the absence of a fracture for decompression, and the timing of surgery is not well addressed. And that's where Michael's study comes along. Don't try and read all this, because I'm going to whip through some of it in the interest of time here, but that this was a well thought out study. It only took the Asia A through D, so nobody that was normal, even with anatomical injuries. And anybody was excluded who was going to have surgery more than 7 days out for whatever reason. These were only for cervical injuries between C2 and T1. And nobody had penetrating injuries. And they screened 470 patients, 4,700 patients to enroll 3,313 subjects. 182 patients went to early surgery, and 131 went to later surgery. That was surgery at 24 hours or later. So the change here was, you are not going to wait, oh, well, I have some operating room time at the end of the week. This is a bad injury. It's the spinal cord. There's no hope. I'll fix the orthopedic problem of the spine when I have time. This didn't make any sense to Michael, myself, others. And these patients then were taken within 24 hours. As a participating institution, the way that we ran, this idea was to not later than the morning after admission. There was probably not enough to have sketchy middle of the night operating room staffs to do this, but to do it first thing in the morning. The bottom line I'm going to put, they are lucky that the median Glasgow outcome scales are 14, so nobody had severe head injuries or that were masked or that developed later. But I think these graphs are kind of easy to see. At 6 months later, looking at Asia grades, so the chance that nobody had any change with late surgery versus early surgery. But you look at early surgery, that people would have a 2-grade change, meaning they go from, say, an Asia D to an Asia B, B to a D, or even 3, those who were Asia B became normal, that these were, and only one patient in the whole trial actually did worse. So the good news is also, not only were we able to determine if there was benefit to patients, but people didn't get hurt in this trial, and that's good news. And so the chance that you were going to improve by at least 2 grades, you essentially double your chances. That's pretty good. That's not just pretty good, that's amazing. There's nothing that's shown this kind of benefit in the world of neurotrauma, except maybe the application of oxygen in the field to brain trauma patients. This is the greatest news ever. I'm waiting for the other shoe to drop for the skeptics to come after this. And if you want to have one grade improvement, that's not likely to be a function of this. So it's big bang for getting everybody together and working quickly. Can't wait till Dr. Dietrich talks next and says, Coplin, you idiot. Complications were essentially split between the group, and that's good to know. About 2/3 of them had what were termed as cardiopulmonary complications, meaning they mechanical ventilation or neurogenic shock or denervated heart type problems. I don't have time to go through some of the heart issues. I do want to cover the last issue, and because I'd be very interested in other feedback. This is a gentleman named Mike Utley, who played for the Detroit Lions American football team. And he's kind of lost in the past. He suffered a cervical spinal cord injury one day, and I've had the pleasure of working with Mike over the past years. This is he now. That could essentially be, he's pulling me sitting on there. He's strong enough. In fact, he'll pull himself out of his chair unless his wife holds him down. So he's done pretty well. But what really brought it to light was the case of Kevin Everett, who for the Buffalo Bills on September 9th, and I've had the ability and with permission to discuss this in medical forum like this, and some of the data I'll show you. Suffered a helmet-to-helmet hit, which has since been called illegal in the rule books. And he was said to be complete below the clavicles, but breathing okay. So below the clavicles would mean C4, so at the best he would be a complete C4 from that description, and breathing normally. That's unusual. He did receive methylprednisolone in the ambulance, and it was given within 30 minutes of his injury. Yes. He also got chilled saline and ice packs to his groin. His hemodynamics were said to be okay. Again, making me scratch my head. Did he really have cervical spinal cord, a complete cervical spinal cord injury without neurogenic shock, breathing normally? Okay. And he was said to be returning sensation in the emergency department. So this may have been as much a case of spinal shock, where it looked like his deficit was much worse than it was going to be. He did have a C3 for facet dislocation. These are his films with permission. And went to the operating room 3 hours after injury. It's amazing when you're famous how everybody gets together, right? The methylprednisolone is in, whether you believe in it or not, because the doctor apparently that had ordered it was not normally a believer, right? Hypothermia instituted quickly to the OR, everything done right, everything like it should be done for everyone. Right? And the next day, he had an intravascular cooling catheter placed and was left at 33 degrees Celsius into the 4th day. He was said to have non-anti-gravity movement in his legs 15 hours post-injury, and that's him now. No spasticity, anything. And hypothermia, well, at least we got some help in the media, was widely credited as the reason for his recovery. There is a wonderful little article then in the journal Spine, authored by one of the audience members here. That's why I figured I'd present this so I can have Dr. Dietrich come and say, Coplin, you idiot. So what is the take on prophylactic hypothermia in and of itself in the current state of affairs? And at least animal studies have been said in the orthopedics one in Spine Journal that there has been no consistent neuroprotective benefit seen. Okay. And that local hypothermia, descriptions such as Barth Green or others taking iced saline at the time of decompression and pouring it right onto the cord, that these have not been published for 20 years. and that there were no peer-reviewed studies describing the use of systemic hypothermia in this setting. Agreed that there was a cogent biological rationale, but that there was little literature to substantiate clinical use. And I happen to believe with this last piece, if you're going to do it, it should be protocolized. You should have permission or knowledge from the patient, at least some statement of no objection, doesn't have to be true consent, and something where it's done the same wrong way every time so you can control for the error. That brings, I told you I'm gonna set the whole table for you, Dalton, what is called the Arctic study. And this is a randomized trial of intravascular hypothermia for 3 days at 33 degrees Celsius for spinal cord injury. Some of us from the outside looking at some of the brain information from Guy Clifton's trial who were best, that the brain patients may have done best even at 5 days if they tolerated it, which maybe he'll tell us why it's so short. It's considered in the review to be based on modest preclinical data with 14 treated patients. Now, I know this has been resubmitted, and please chime up at any time. The use of methylprednisolone in the initial offering was left up to individual treating physicians. Openly, in another country, I beg you to standardize it. It was considered to have limited preclinical data and not funded on the first go-round, but going back for submission. At any rate, I think I'm running my time. Remember that even if we save one spinal level, and Michael Felling's study shows that you doubled your chances of saving 2, that this becomes important, because if you're C2 through C4, you're stuck as a high quad. If you, C7 is the real kicker, because once you can use the triceps, you can move elbows, you can pull shoulders back. When you can pull your shoulders back, you can use a wheelchair.